this evening, moderated by a renowned award-winning journalist and activist, Charlene Hunter Galt, and my new best friend. And I have to tell you that as someone who has been involved in AIDS work for more than 25 years, as many of you have as well, I started when I was 6, I don't know about you. I'm incredibly grateful that we can all be in this room together talking seriously about the end of AIDS, which until recently, even the idea of which was a fantasy. The title of our session shows how much things have changed, getting real about getting to the end of AIDS. We've heard a lot of talk lately about an AIDS-free generation and ending global AIDS. So amfAR and AVAC wanted to bring a group of insightful individuals together to talk about what that actually means, what will it take to end the epidemic. When the conference is over and it's time to roll up our sleeves and get back to work, what do we have to do to achieve the goal that we've all been dreaming about and one that we are now finally talking about? I am confident that our wise panelists will bring insightful, thoughtful perspective to this conversation. And without further ado, I'm going to turn it over to two devoted individuals who have worked tirelessly every day towards our shared mission and who have pulled this all together this evening. First, my colleague Chris Collins, amfAR Vice President and Director of Public Policy, and his partner in this project, Mitchell Warren, Executive Director of AVAC, which again has partnered with us, and they do extraordinary work. And together, by the way, you'll probably hear about it tonight, they worked on an action agenda to end AIDS, which is an extraordinary document, which I think you'll enjoy hearing about. Thank you.
Thank you very much, Kenneth, and for your continued leadership in the fight against HIV. So thank you again for being here tonight. I know you had a lot of choices tonight. There's wine in the back. If you didn't know that, please avail yourself. It's wonderful to be partnering with AVAC in this work. And I think we had a great, wonderful start off to this conference today. There's a consensus about the goal, where we're all heading here, an AIDS-free generation, the beginning of the end of this terrible epidemic. But I don't mean to be a downer now, but to paraphrase Dr. Fauci from a couple nights ago, we now have the means to begin to end the epidemic, but it isn't automatic that we're going to do that. Achieving that goal is going to take investment, and it's going to take research, and it's also going to take tough choices and setting priorities. So we want to be, tonight, to be a place where we can talk about what we need to do in the near term, very specifically, to take advantage of the tremendous opportunity we've got in front of us. What are the choices we have to make? What are the tough decisions? Now, I don't want to make it too easy for you, so I'm going to take some things off the table as potential answers for tonight. Let's posit for tonight that we already know we need more investment. We need more investment from wealthy countries, and we need more investment from the countries that are most heavily affected. So you don't get to recommend that. Second of all, we need a cure and a vaccine. We won't truly end this epidemic until we have a cure and a vaccine. So we know that. You can't recommend that one either. Tonight, what we want to do is focus on perhaps the less obvious things, but just as important choices, places where there may be less consensus, but where we need to go if we're going to be strategic and get the job done. So the real question for tonight, I think, is what do people in all variety of different roles, including researchers and donors and policymakers and advocates and implementers, what do we need to do when we leave this conference? Really, we're talking about what must we do over the next 12 to 24 months to move us, to accelerate us towards beginning to end the epidemic. We want to be as specific as possible. As Kenneth said, we have come out with a report tonight with some ideas and suggestions. You can use that as a starting off point for your thinking. Mitchell will guide us through a part of that report. It's a little audacious, this report, because it presumes to say what needs to happen in the next 4 years, put it on a timeline like it really happened. Now, I'm going to admit right up front, we probably got some things wrong, and probably not everyone agrees with our timelines and the decisions of the future and the research that will be, and the discoveries that will be uncovered. But we wanted to start the conversation, and we know for sure we need to start having this conversation about the choices and the decisions and the priorities that we're going to need to look at over the coming year. So, we encourage you to have some wine, which may help you be audacious with us. And with that, Mitchell Warren.
Thank you, and I rest assured you did not come to hear Chris and me as much as you came to hear this panel. We are so excited that you all are here and that you did choose this. I will be honest, we didn't come up with this document since 10 a.m. this morning when Secretary of State Hillary Clinton said, here's a vision, now we need a plan. We couldn't have got the printing done quite that quickly. But many of us, not just amfAR and AVAC, but many of us have thought about this deeply, that it's not enough to have a bold, audacious goal, but what are we going to do to reach the vision that we all have? No real slides for tonight because you've sat through way too many presentations. I did just want to quickly explain that when we thought about this, we really wanted to get all of us, advocates, policymakers, scientists, communities at large, to think about the things that we needed to do to achieve these things, which I don't expect you to read on this eye test. You hopefully have the reports in front of you. But to give you a sense that if we do some specific things, which hopefully this panel will describe, we can achieve some great outcomes. And this is our vision for the future. Perhaps a little complicated. We think it's really exciting. You'll see it has a yesterday, the last 12 years of what's happened since Durban 2000. And we lay out an advocate's vision of what the next 5 years should look like. And our hope tonight is to get the panel to talk about how we actually achieve this. And I want to just have people think about this. I don't know when it's going to happen. But this point, that tipping point, is a very specific desire, a very specific goal. The day that we can say we have more people newly on treatment than newly infected, so that the UNAIDS reports begin to change the curve. And so really it's about how do we get there. We actually had the bios printed out, so we didn't take a lot of time this evening. I'm going to turn this over to Charlene Hunter-Gault, who is a remarkable journalist and activist, as Kenneth said. And she's going to moderate this panel that includes some of the leading thinkers. And you see Dr. Fauci, who is still standing. Well, he's sitting now, but still standing, and after an absolutely incredible presentation this morning that really began the process. Just to say, we have Nono Simelela, who is the special advisor to the Deputy President of the Republic of South Africa. Helen Rees, who runs the WITS Reproductive Health and HIV Research Institute in South Africa and wears many hats both in South Africa and globally. Millie Katana, a leading advocate in Uganda and the world, who's been involved in a number of efforts in Uganda to make things happen, as well as early involvement in the Global Fund. Debbie Birx, who, in addition to being the head of the Global AIDS Program at the Centers for Disease Control and Prevention, is in some ways, I can say, the godmother to Chris and to me. If we're partners, she's our godmother, who really got us both thinking about this idea, this tantalizing vision of translating science into the end of an epidemic. Mike Cohn, who a year ago stood in front of all of us in Rome and delivered a scientific result that translated lots of hope into evidence through HPTN 052 based at the University of North Carolina. Nelson, whose surname I will mispronounce, who is from Kenya, who leads the network of people living with HIV and AIDS in Kenya and a leading advocate there. And finally, I will happily turn this over to Charlene.
Thank you so much, Mitchell. And thanks to Kenneth Cole and Chris Collins, and as well as you, Mitchell. I don't have to do anything but ask a few questions, which I've been doing for 50 years, so let's hope I can ask the right ones tonight. And I want to start with Dr. Fauci, who I want to second everyone's accolades to him. He really laid out what we have to do brilliantly this morning, and I'm glad that he is still standing, although he is sitting at the moment. Dr. Fauci, you've heard everybody now say that within the next 12 to 24 months, we may achieve the breakthrough that we need towards ending AIDS. Now, I want you to get real, because that's what this panel is supposed to be about. Tell us exactly, what is a realistic time frame? Is it 12 to 24 months? And what needs to happen within that period?
I'm trying to restrain myself from saying something that will get me into trouble, but whoever said 12 to 24 months is living on a different planet, I think. I'm sorry, whoever that was. You cannot put a time frame on this at all. This is the same situation we had when the virus was discovered and there were predictions about when you had a vaccine. And that's the point I try to make in my lecture this morning, that we have the science that gave us the tools of the interventions, and we know that they work under optimum circumstances in a clinical trial, which is called efficacy. What you need to do, and we've been successful in some situations and not so successful in others, is to translate efficacy into effectiveness, namely it actually works in the field. So I promised you I'd give a short answer, so I will. I can't give you a time frame on any of this, Charlene, because there are not going to be breakthroughs of things like vaccine and a cure. We may not ever get a cure, though we're going to try. A vaccine, we have one positive, and I can't put a time frame on anything. So if there's a breakthrough that you can predict in 12 to 24 months, by my definition, it isn't a breakthrough, because if you know what it is, then you've already done it. So I don't know what it is that people are referring to.
Okay, well, you're helping us with getting rid of our false expectations.
Yeah.
Give us some of the steps, however, that need to be taken regardless of whether it's 12,
Right.
24, 36, or what. Give me 3 or 4 steps that really people need to take starting now.
Okay, so I can give you a concrete example, because it's going to differ with different cities in this country, differ with other countries, and different within regions in other countries. So right here in the middle of Washington, D.C., what do we have to accomplish to really do this? So we have a city, for those of you I know from all over the world, this is a city of about 600,000+ people, the majority of whom are African American. And we know that 13% of the population is African American, and 50 to 60% of the new infections are among African Americans. So Washington, D.C. is kind of the prototypic example of an area that what you need to do is you need to penetrate the community, access them, get them tested voluntarily, linked to care, put on treatment where treatment is appropriate, keep them in care, and have them adhere.
Let me just stop you right there, because everything I've been hearing all day is that getting people to test voluntarily is a real challenge. So how do you do it?
Yeah, it is, but what I think people are not really fully giving credit to is the power of the commitment of the community. And I think Phil Wilson said that extremely well this morning. When you get the community to take ownership of a problem, they can do much more than what any government official or any organization can do. And that's what we finally learned in the district, that we're getting community workers to go out there and really start beating the bushes, getting people involved. They're doing the same thing in the South Bronx, 2 areas where you never would have predicted that that's going to happen. And all of the other things, like a white guy in a suit coming in and saying, you got to do this, doesn't work. You get community workers going in, and all of a sudden people bond with them, and that's how it happens.
No, Simelela, you come from South Africa, where I've lived for any number of years, and know the struggles that you have had up to this point, but you now are past the struggle point and have achieved success. Is it related to what Dr. Fauci has said, getting the community involved, or how else do you explain it?
Thank you for the question. I think it's a combination of both, but in South Africa, given the history, it is just bold political leadership that's taken us beyond the points that we were, where we were not doing what required to be done. The leadership is aligned with the issue. The leadership understands, government is committing resources, and the people are following. I think on Tuesday, tomorrow, you will hear results of a communication survey in South Africa that will show you what leadership can do, how people responded, when the leadership said go and test. And that's an independent evaluation, which I will not elaborate on now, just keep it for tomorrow. But I just think for South Africa, it was a combination of leadership, an activist community, and I think a country of people who were tired of the fact that we were not moving. That's why people have embraced this new momentum and are moving on.
How successful have you been? We talk about success, but what is success in South Africa?
Success in South Africa is a number of things. I mean, the sheer fact that we've got 1.7 million people on treatment, something that everybody said was impossible to do in Africa, is incredible. Success is the fact that our researchers are able to sit at the table with policymakers. You didn't see that. There isn't that ongoing conflict. Success, you can see in the townships where people are talking openly about HIV, And just before I came here, actually I had a guy who was just paying for something in a shop where I live. And he sort of jumped the queue and said to me, I've got an emergency. And I said, okay. So he was paying for a packet of condoms. I started clapping. I mean, it's incredible. He was having an emergency and he's in a supermarket. And the first thing he thought of was, let's go buy condoms. So I think we're getting there, Condomizing is becoming the thing to do. So,
finally, let me ask you, South Africa has considerably more resources than most of its neighbors, and in fact, most of the countries in Africa. Can the things that you've done in South Africa be replicated, say, in Malawi or Zambia or Benin, for that matter?
Yes, I don't think that what we've done is necessarily impossible in other countries. We've just been lucky in that, the resources have been available, the research community is vibrant, and the activist community is vibrant. But there are many people from different countries in Africa who are in South Africa, and there are also experts who come from other countries. So I don't think it's impossible. I think if we get out of the man-made borders and boundaries that stop people from moving, and South Africa starts to share its knowledge and encourage and move with the region, we'll go much further.
Thank you. Debbie Briggs. Major funders like PEPFAR and Global AIDS have been losing funds. In fact, I can't remember now. I've heard so many reports during this AIDS conference, I can't remember who said what. But somebody said that the elephant in the room is who pays. How can you even talk about the end of AIDS, whether it's 12, 24, 36, however many months or years it is, if you are seeing such a decline in the funding for organizations that have been critical to whatever successes have been achieved to date?
Everybody always asks about the money because we government organizations often give out money. But to me, it's always about the people that make the programs. And for 9 or 10 years now, this program in Africa has been, and around the globe, people who are implementing programs. For every person in the room here, there's probably 10,000 people out there every day going house to house, community to community, clinic to clinic, hospital to hospital, to ensure that services are available to the far reaches, whether you're urban or rural. And it's the people who are coming to access those services that have chosen to stay on drug, have chosen to come to the clinic and be tested as a woman who knows that it could be stigmatizing to protect her baby with no hope at that time to receive life-saving drugs for herself. And that has totally changed. So I think, I heard over yesterday and today a real commitment, but I also heard from Michel Sidibe last night that countries are stepping up and increasing their own commitment to HIV/AIDS. So this is the first conference I've been to where it seems like the global community, the community of healthcare workers, the community of activists, the community of government officials, the community of donors are all saying exactly the same thing and saying that it's in our collective hands to take the next big step. I remember a conference not so long ago when people were saying that HIV-positive patients in remote villages wouldn't remember to take their pills. Well, incidence wouldn't look like it does today if they weren't as committed as we are. So we shouldn't make assumptions that patients and others are not as committed as we are into making the changes that will end AIDS.
All right, you do have a global perspective, and you heard Nono Simelela say that one of the active ingredients in South Africa's emerging success is leadership. Do you see political will to do the kinds of things that we've heard about so far uniformly, or how much of a problem is that? And if it is a problem, how do you get beyond it? Because that was South Africa's problem for a long time, right, Nono Simelela, political will?
I think we've learned in watching South Africa move together is when the activists and the donors moved together, it didn't require always that high-level leadership, that you could move forward together if you had enough people who believed. I think we've also learned, though, that when political leaders take their eye off the ball and assume that the epidemic has passed them, that you can end up with the resurgence of the epidemic.
So what do you do to keep that from happening? Or once it begins to happen, what do you do as activists? I can ask the activists that in a minute, but let me get your take on it.
I think holding everyone accountable.
How do you do that?
The way they did it in South Africa, the way they did it in the United States, the way they came to the NIH and demanded new science, new drugs 20 years ago. The power is really always been here with us. And I think that when we've utilized it, we've been extraordinarily successful. I think that it's that kind of continued excitement that is needed right at this very moment to ensure that we all get from the 56% coverage we have now in sub-Saharan Africa for ART. I can't even imagine that I'm saying that. 56% coverage at 350 is to get that to the 80 to 100%, to get to the 15 by 15. It's possible because we've shown that we can get as far as we have without even really knowing the roadmap. And now we have an amazing roadmap from the team up here. So I think, you know, we should be very excited about these boxes on the roadmap, but behind every one of these boxes is probably another 10,000 people pulling in the same direction to ensure that box gets accomplished.
Thank you. Mike Cohen, your groundbreaking research regarding the positive outcome of putting HIV-positive people on ARVs came out a year ago. How does that advance the end of AIDS in specific? I'm not going to cross Dr. Fauci and say in, 12, 24, 36 months, but do you have any sense of how your research can be translated into the real world and make a concrete difference among people who are not in a test?
I guess in the sense of this roadmap, and I'll disagree with Tony, not disagree, I can never do that, but I'll comment on Tony's comment. I think that the point of our finding was it gave a number. People believed that treatment would serve to reduce transmission and that earlier treatment was better. But our research then and presented this week demonstrates that early treatment improves health, even more than we presented last year, and that treatment, when taken properly, can prevent transmission, essentially. So then the question is, we just need to apply it. But my problem, and this is why I like the AVAC map, is I don't know why the goal is 6 million, and I don't know why the goal is 350 at a CD4 count. The goal is to treat 34 million people. And I realize how difficult that is, but that's the aspirational goal. But then you require some magical thinking, and this is where Tony got into not wanting timelines, which I think is appropriate in the sense that we don't know when someone will cure HIV or when a vaccine will be generated. But if we treat as many people as we can treat, what I'm 100% sure about is the disease won't be treated the same way 10 years from now. Because 10 years ago, we had a whole different mindset about what we were doing, and 20 years ago, we had no treatment. So I'm really sure with what we're learning at this meeting and moving forward, it'll be different. And so what we're really doing with all this treatment, this cannot end the AIDS epidemic. We need a vaccine and a cure, as Tony said, but we're making a bridge. And this bridge requires an aspiration. And so my thought about that is, what I'm amazed about is normally the scientists are fighting with the politicians, saying, you know, give us more money and you're not interested. Well, here the politicians are driving the scientists. They invented the AIDS-free generation idea. They're the catalyst. Having said that, I don't really understand why we're not making our aspirations incredibly high. My friend Kevin Frost talked to me about this today and thinks that we should have the highest possible aspiration and as this bridge to what's 10 years from now. And all the Tony.
Yeah, so I don't disagree with having high aspirations at all, but I think Charlene asked me that we were going to turn around the pandemic in 12 to 24 months. That's what sort of threw me out of my seat. So that's what I meant. I'm not saying you shouldn't have timelines, because I have no idea where that number's coming from. But I keep hearing all day with panels and press conferences something I would really like to try and clarify in a minute, just in a short period of time. And my good friend and highly esteemed colleague, Mike, said the same thing. End the pandemic with a vaccine and a cure. We really got to be careful with the word cure, okay? I am very, very much committed to developing a cure for HIV. But what people are misinterpreting is that a cure means the end of the pandemic, and the end of the pandemic means a cure. That's not so. So let me explain, so at least this audience, which probably understands it, so it's very clear. The end of the pandemic is an epidemiological phenomenon. It's having virtually no children born infected. It's having a very sharp decline in the incidence of new infections. And it's essentially getting everyone who needs therapy on therapy. If you do that, the trajectory of the pandemic will go like this. A cure is to take someone who's already infected, already treating, doing well, and getting to the point where you can take them off therapy without the virus bouncing back. So in reality, you could end the pandemic with curing no one, or you can cure 1,000 people and the epidemic could still be out of control. We really need to understand that. That's different than a vaccine, because a vaccine is a very potent component of a comprehensive prevention package. We have all the things you mentioned, and I won't go through them, all of the combination preventions that I mentioned in my lecture. If you stick vaccine in there, you make it much more robust. That would contribute to ending the pandemic. But ending the pandemic doesn't necessarily mean a cure, nor does a cure mean ending the pandemic. Now, when I say that, people say, you're not committed to a cure. No. My institute is spending more money on a cure than anybody else combined. So we really are committed to it. But let's make sure we understand what we're talking about.
I think we got that.
No, I mean,
I think that's a very good point, and I'd like to pursue that with some of the other people, especially Helen Reese. But let me just go back to Mike Cohen for a moment and ask him whether or not, or where, if at all, your protocol is being actively implemented.
So,
you did it in 12 countries, your study, right?
No. The study itself is in 9 countries, 13 sites on 4 continents. But what happened is, and this is very unusual, as soon as those results were available, policy changes occurred at a very rapid rate, and this was reported in Health Affairs. Usually policy changes are very slow. PEPFAR had a committee that immediately modified their policies to reconsider exactly how they wanted to optimize treatment, taking into consideration the prevention benefit. The WHO has had two events, but their most immediate was looking at couples and saying this study was in couples where one person's positive and the other's negative. what they recommended was every couple should be told about these results, and that from WHO's point of view, that an infected person in a partnership where the other person's negative, that person, regardless of where they are in their disease state, should be treated immediately. Now, again, this is somewhat aspirational, but these policy changes took a scientific observation paid for by the NIH and NIAID and made it real very, very quickly. Helen might want to comment on the, or
well, in a minute, because I want to ask you one more question, and that is, how do you scale up from a reality in which less than half of the people needing AIDS therapy are getting it? I mean, give me something practical in terms of how you do that.
Well, you know, this is beyond my pay grade. However,
well, give it a shot.
But what I can say is that the United States, with the two main guidelines, has indicated that in the absence of any intervening forces, that people should be treated immediately. That you get a test, you're positive, the message is simple. You should be treated for your own health and for the sake of your community. I believe right now we're still troubled by our lack of resources and lack of drugs, but I think as the message gets bigger and bigger, some countries, certainly all countries, are aspiring to start people before their health is jeopardized. Many countries have taken their couples and said, like Rwanda, for example, said we're going to treat couples right away. So I think you see a movement. And these movements, I'd rather the people living in these countries, like Helen, would comment on what they're doing in response to the belief system, which is a belief system that's turned into a reality.
I love it that everybody's taking over my job. So Helen, why don't you answer the question?
Thank you for allowing me to take over.
I mean, I think that there was an enormous impact of that study at a local level, and we've certainly had quite extensive discussions about what we can do in the constraints of our budget. And because of the numbers that we're looking at, we clearly cannot make the jump to the test and treat. It just wouldn't be feasible. So, but what we have done is, as Mike said, it has allowed us to have the impetus to say, well, we can go to 350. It's good for the individual. It's good in terms of prevention. We can't go to 350 across the board for everybody first, so let's take the priority groups who will get optimal individual benefit from earlier treatment. Let's start there, and let's move up to that, and then let's get everyone at 350. And when we get there, we'll then think about moving on.
But who determines it? Because the other criticism I've heard in this arena is that there's a lack of coordination and a lack of setting priorities. So who should be listened to as you begin to pursue the path that all of you seem to be talking about?
I mean, clearly, I started off now talking at a national level, and clearly we need to mobilize at national level, and I think we are seeing that in the highly affected. I don't think there's a single country that hasn't got its eye on the ball at this point.
You mean in the whole world?
No, I'm talking particularly about sub-Saharan Africa, mm-hmm. But so I think that those countries have really taken up the mantle. But I think that globally, I think that this is a bigger challenge, because I mean, I'm struck when we get very enthusiastic, and if you notice, this excellent document is beginning to end the HIV/AIDS pandemic, so it isn't 12 months. So, but I think we've got to look at some lessons from other fields, and the two that I was thinking about were TB on the one hand and polio on the other. Now, TB, we've got a limitedly effective vaccine with very limited utilization, but we have got a cure. We've got prevention, we've got public health measures, we've got the Stop TB, and we failed. And we've been saying that we want to do something about TB for years, and we failed, and we've got the tools. Polio, which admittedly, and I agree, is in a sense easier because it's a highly effective vaccine, but we've had an enormous global focus with a single governance, big piloted and focused budgets, World Health Assembly, governments held accountable and having to report. So we need to make sure that this doesn't turn out to be rhetoric, and we end up a bit like the poor TB field has been suffering because we just haven't been able to really galvanize. Now, we've got a lot of momentum in conferences like this. The reality is when we go out of the door. So the question I think we have to ask ourselves, if we're serious about this, is are there other things we can do at a global level that will really, really help mobilize and focus global thinking?
And how would you answer that question?
I think that we probably should be thinking about it. I mean, we've got international donors, we've got countries. I mean, we're very good at having World Health Assembly statements, and we hold people accountable. We've got an MDG around HIV already, but why don't we actually think about what we do with these tools if we're serious about taking this now onto a global stage? And who would then hold us accountable, and can it help hold countries more accountable, which certainly, as I say, other global commitments have.
How realistic is it to think that you could have some global entity that mediates all of this and coordinates all of that? Is that possible?
Well, we have, if we look at TB, there is Stop TB, and I say it hasn't really been effective. But the World Health Assembly is an effective forum. The UN is an effective forum. We've got an MDG around HIV. But why don't we relook at all of this and actually have a very serious discussion? If one of the statements from this conference is we can begin to stop the epidemic, why don't we then say, what is that next international step that would use established mechanisms to try and achieve that?
And who would that we be?
Well, I think we've got governments here, we've got United Nations, we've got the UN bodies here. We have very powerful bodies such as PEPFAR and such as the US and the multilaterals who are already investing. So I think we have a large number of people who have an international stage, and perhaps that's the question people should be asking.
I want to get to our two other panelists in a moment, but I have to go back to Debbie Briggs and ask her if what Dr. Reese is saying is realistic. I mean, can you get that kind of global cooperation and it be more than a talk shop? Can you get something, one entity that can coordinate all of this, that everybody will listen to?
Well, I think that we also have to remember that the epidemic is different in each country, so that a single plan is not going to work in a global approach. I think we do have what I heard last night from Michelle Sidibe, who came from an African Union meeting, that there was really coalescence around a plan and moving forward with a really concrete plan. I think that will help tremendously to have that kind of leadership on the continent at that overarching level. I think it's difficult to make the tent big enough to say that this is the plan. I think it's important. I take us back to a meeting that was one of the pre-meetings, and letting people have incredible innovation. Hearing the Mozambique team who said, we had designated one person to go to the clinic to get the drugs for the rural community, and we all chipped in and we paid, and they went and they reported on everybody else and brought all the drugs back, and we rotate that and a different person goes the next month or every 2 months. And it was, what we don't want to lose is that unbelievable grassroots community innovative ideas at the same time that we have that umbrella of government accountability.
That brings me to Millie Katana from Uganda, where I visited several years ago, and it was a success story on the AIDS front, and now I'm hearing that it's not as successful as it once was. Is that incorrect information? And just so maybe tell me if it is, or incorrect information, and if it isn't, what happened?
Thanks. Just to echo Dr. Fauci, we can attempt to cure an epidemic, but if we do not address the predisposing factors, the epidemic will still remain. And that's what has happened in Uganda. We attempted to fix the symptoms of the issue, but we never addressed what the real drivers of the epidemic was.
And they were what?
One of them that I would like to focus on is effective use of available resources. And I think this should be one of the critical issues as we are beginning to look at how to end the epidemic. And you asked this question to my colleague from South Africa. My opinion is, yes, we need resources to respond to the HIV epidemic, and we need to use the resources more effectively, deal with the loopholes as far as the use of these resources are concerned. What helped us in Uganda to get to where we got those years was not so much money. It was what we called barefoot doctors. Old women, some of you may have seen posters, grandmothers who have barely nothing, but they were up front helping communities and individuals. They did not have so many millions of dollars. People living with HIV, helping each other. We did not have so much money. We need the money, but we need to use that money more effectively.
But there was a time when the entire country was mobilized around AIDS, and then there began to be political interference, if you will, about it, and mixed messages coming from top leaders in Uganda. Has that been fixed?
I think as human beings, one of the problems we have, once we get into a state of comfort, we sit back and we get into a state of slumber. My belief is that that's what happened with us in Uganda, and the leadership took on other priorities, imagining that the HIV epidemic is relatively under control. And before we realize, we are seeing more new infections happening, and the prevalence rates are increasing, and we need to get back to square zero.
That's one of the things that concerns me with all the talk about ending AIDS, is the fact that, well, not the fact, but the possibility that people will become complacent. I've heard around this conference that even in America, black HIV-infected people are suffering the most because the push to treat has receded as more and more people have access to care. So how do you overcome the kind of complacency that you're describing? And is it happening now in Uganda?
My take is we need to get ourselves together, particularly the activists, so that we get the AIDS agenda back on the table. And we continue working together, getting everybody's best expertise, comparative advantage on the table. As we got more money into the AIDS response, the partners who have influence took the center stage, and the grassroots actors kind of were sidelined, and that's not a very healthy situation to be in. So as we get the science to help us with paving the way to end the epidemic, we need to be galvanizing the partnerships that are needed to be able to get on top of the epidemic.
Nelson Otomo, you are in a similar position in that you are an AIDS activist in Kenya. How different is your experience from Uganda, and are you suffering from either activist complacency or donor fatigue? And if so, how do you get beyond that?
Thank you very much, and allow me first of all to say that I'm very encouraged by the word reality, the reality of ending AIDS, because that is what we are talking about here. But I also want to say that apart from the scientific breakthroughs and all this good information coming from the science and laboratories, I think this information needs to be out, and this is what we've tried to do in Kenya, to make people living with HIV understand this science. And in understanding this science, it is not beginning now among people living with HIV, because when ART was helping mothers not to infect their children, that was treatment as prevention. When people stopped having TB, when ARV were rolled out, that was treatment as prevention. So we have that experience combined with the science. So we also believe that we are part of the team having the dream or a vision of starting to end AIDS. But like everybody in this panel has said, there's some but, and this but is that we have to go back and recollect. And in terms of going back and recollecting, we have to go back to what Dr. Anthony said, that please let people know their status accurately in a manner that respect science but also respect their human rights. So the word is still voluntary and confidentiality, privacy and testing. We can educate people to access it. After doing this, I want to bring to your attention that when ARVs were introduced in Africa, particularly in Kenya, government said we could not afford, and WHO was calling us low resource setting. So the strategy that was not written down but was used to propagate ARV was to try to delay people, to discourage people, and talking about the side effects and toxins. And that went to the back of the mind of everybody, including people who have HIV. So the strategy among people who have HIV in Africa and in Kenya, including the network where I work, is to delay ART to sometimes the last minute, such that when WHO revised guidelines that people start treatment early, then people had questions. And that is the role we have to go to. In other words, all these scientific benefits of early treatment must be disseminated to people who need that treatment. Secondly, people who need that treatment, and I'm one of them, need to be convinced, it depends on the language, they need to be told that that treatment they are taking for their own benefit, to improve their quality of life. And this is because when they were being given ART a long time ago, they were told this is to save your life, or this is to prolong your life. But your life can be saved and it is miserable. Your life can be prolonged and it is miserable. So what we are looking for to be part of the scientific community and global community working towards this to end AIDS as part of combination prevention is to be told that this is for the real benefit of your life.
And now, who's to tell them that and have them believe that? The priests, the politicians, the AIDS activists?
Everybody.
Yeah, but who?
Starting with the clinicians and doctors, and I've said that what we do in our national network of people living with HIV in Kenya is to get those who really understand this scientific information and then disseminate and share back. That is the education that we are looking for. And that education will then galvanize everybody to move in the forefront of trying to stop HIV and AIDS. But I wanted to go back to your second question of sometimes going up, sometimes going down. I think I want to agree with Dr. Katana that once we start, it is like ART, it is lifelong. When we start fighting HIV, even those who are HIV negative know that you are in a lifelong, and I'm encouraged by Dr. Fusi's message that yes, there will be a cure, but it is not tomorrow. So don't start fighting HIV today thinking that in the next 10 years, then you will go to fight something else or build roads. It is lifelong in this generation, even though we are saying this generation can end it. So let people not get fatigued. And let us not go to the word of saying, today we don't have resources, so please let us integrate. Where did resources go? And we have also to go back to our countries and tell our countries that please own this disease. Treat your people who are sick. It is not just PEF and Global Fund. Let us have domestic funding, putting money on treatment, so that people who need treatment can be on that treatment. And this is because as people living with HIV/AIDS, before you start that treatment, there's always one question. Is it guaranteed that there will be no stockouts? And if that is guaranteed, then we are going to be part of this team working through combination prevention to make sure that HIV/AIDS is brought to a halt.
I want to go back to your question about your answer that you say everybody has to do this. Yes. Because I know that in Africa in particular, the churches have had a mixed record on speaking on this issue. So, and yet there are many people who go to church and who go to mosques and so forth. How involved are the institutions that actually do in fact reach people, and how do you get them more involved? Is this something that you AIDS activists have to do, or what?
Yes, it is true. There are people who will tell AIDS patients that if you come and I pray for you, you can get healed of HIV/AIDS. Those are retrogressive, but they still exist. But their number is reducing because everybody is now beginning to understand science. It used to happen more when testing and counseling was not widely available. And right now we have religious leaders who are themselves living with HIV. These are really champions who are helping us. And if you had a group called INERELA, which is International Network of Religious Leaders Living with HIV, and they exist in each country, these are real people who are telling us that, okay, they are people of God, yes, but science probably is also coming to save everybody, including people of God. So we are slow in that area, but we are convinced that if we educate everybody and I like using the word we because it starts with people in the HIV/AIDS, but also governments and clinicians. We are going to get everybody in the table fighting HIV/AIDS.
Just finally, how successful have you been in overcoming stigma? Because that's a huge barrier to getting everybody tested and on treatment.
Yeah,
have you been successful in Kenya? And can you
I
share?
think stigma is still a big issue depending on where you come from. In the religious community, still very high. If you come to Kenya, you go to northern Kenya where it is Islamic, the stigma is very high. Stigma among professionals is very high. But we've also been studying what do people really stigmatize? If today I'm here and I don't feel stigmatized, but I'm sure if I was here and talking and almost coughing all the time and scratching all the time, people stigmatize that opportunistic infection that you may carry. So if we put people on treatment early, even the stigma is lessened. Because then, today I can talk about my HIV status, but not everybody, it is not a must that even in our network, you have to talk about your HIV status to access that treatment. But I think it is that sickness and that apathy and that hopelessness that was also camouflaging this stigma. But we still have to educate people. We have, through the support of GNP+, we've administered tools under what we call HIV leadership through accountability, stigma index, to try to explore with the people and generate discussions on why do people stigmatize each other and what do they really stigmatize? So if we can identify what is this that is stigmatized, one of them being opportunistic infection, and remove it through treatment, then we are lessening that stigma. If we get more people coming up to talk about their status and they are there, they are working and they are paying tax to their government, I think that is also working on stigma. This is also part of what we've learned from Uganda, that because their leaders, including religious leaders, went out and talked about HIV/AIDS and it became a human reality. So we are there, but not yet complete, but stigma is lessening by the day.
Okay, I'm going to ask Nolo to just comment on that as I invite members of the audience to come up to the various microphones that are around the room. If you have questions for any of the panelists as you start to get ready, may I ask you also, as I've asked the panelists, to be pithy and brief so that we can get as many interventions as possible. Dr. Fauci, do you have a comment on this stigma issue? Sorry, that was Nolo. I meant to ask Nolo, and then Dr. Fauci. You don't mind if I call you Nolo, do you?
No, I think stigma is still real. I don't think it's completely. I think there is still stigma, even in countries like South Africa, where more and more people are on treatment. You still get people who do not come to the services either because they feel discriminated against or they just are not treated in a way that you would expect to be treated at a facility. That is a day-to-day occurrence. I think it's going to take a long time because I don't think stigma is just around HIV. As human beings, we just discriminate against each other because you don't look like me and you look like, you know. So that's that. We don't like difference. You know, we want sameness. So I think this builds on. But also, if you've been in the response, you know, I'm sure Helen can attest to this. I find that in South Africa, people are talking more and more about HIV. People are actually talking about being on treatment, and it's not as bad. But there are still people who can't or will not access services because of stigma. So I don't think you can say everything is done and dusted on stigma.
And briefly, Helen Reese, did you want to add to that?
Well, just to quickly build
Can
on...
you pull that up a little bit so I can...
Just to quickly build on what Nono has just said. I mean, people who are on treatment, one of the common visions, and when we take people around the clinics where I'm working, every day we have dustbins that are full of the boxes that contain the ARVs. So people are going, they're on treatment, they're keeping their ARVs, but they throw the boxes away so that they cannot be identified. Now, so we've got to the point where we've broken down the stigma for people to come forward for testing and to go on to treatment, but we haven't got to the point of confidence where people are willing to talk about it. And so that's why things like PrEP are going to be very challenging. But I think, as Mike said, history is going to show us that slowly, in 5 years' time, 10 years' time, we will build on this and we will continue to break down these barriers as long as we keep doing what we're doing now.
Okay, thank you. Let's see what our audience has in mind. Yes, sir. Could you identify yourself, please, and say where you're from?
I'm called Moses Supercharger. I'm a musician and person living with HIV from Uganda. We certainly can't end AIDS without sorting out the issue of human rights. As you know very well, my country is one of those countries that have the human rights issues. As a person living with HIV, I tell you that some people cannot access treatment because of their sexual orientations. We need to sort that issue out throughout Africa. Secondly, Uganda was doing very well, as my Dr. Katna said, was doing very well. We were #1 in Africa, but now we are like #3. But we know the reasons why. One, some people cannot access treatment. Two, the biggest organization that were offering treatment, that is Joint Clinical Research Center and TASO. Joint Clinical Research Center had about 130 clients, but it was told to cut down its client by a half. It just dumped them there.
So your question is?
We need to put people on treatment if we are to end HIV. We need to put.
So do you have a question?
Yeah, sorry?
Your question?
That is my concern, that if we are to end HIV, we need to put the issue of human rights at the forefront and to all people, to give people equal chance to access treatment.
Thank you. I think that was a point that was raised here by the brother from Uganda. And Helen, I wanted to ask you about that, or Dr. Fauci, about this whole question of human rights issues as it relates to HIV. Dr. Fauci, we haven't heard from you in a while. Can you talk about that for a minute, and how you get more countries to recognize the human rights issues involved in HIV and AIDS?
Well, Jonathan Mann identified human rights as a major issue with HIV a very long time ago. And I think it's still an issue and varies greatly from country to country. To be honest with you, Charlene, I don't know in a country that doesn't have much respect for human rights or women's rights what we can do from the outside to change that, except put pressure on a country the way we've put pressure on other countries for other things. I mean, the pressure that was put on South Africa during apartheid had a major, major impact. And I think if we can put that similar type of pressure on countries in which human rights are not respected, that we could get some headway with that.
Thank you. On this side, please.
Jim Copeman from Michigan. My apologies for turning the discussion a little bit toward the United States when most of the focus here is on Africa. I've been listening. My God, I think it might be easier to address the problems in Africa than it is in Michigan. I mean, you know, Michigan CDC budget is cut down because CDC made the decision to even out, to spread the funding in exact correspondence to the number of cases. And so that means funds come out of Michigan to go to places with higher. But by that logic, by the way, I would think that they'd stop funding prevention of maternal to child transmission in CDC, since there hasn't been a case since 2009.
So your question, sir?
Can we make, when we get down to the practical small level of making decisions, we've been talking about making decisions at the big upper level. But let's think about, you know, the people in the field who have a lot of different things that they could be doing. The people that are running prevention programs, the people that are running partner services programs. Their needs, their potential things that they could be doing are so much greater than the resources that they have.
So are you asking, where do you get the resources for people at the local level? Is that your question?
No. How do we focus? What can we do to better focus the decisions that people make at the individual, the smaller level, and not just the bigger level.
Okay, okay, I think we got that. Would you like to answer that question?
Yes, that's a very good question. We are sitting here this week and we are getting energized, and we need to get back to our countries and look at our national plans. We look at our prevention priorities. We look at our care priorities and see how to integrate the issues that we are getting fired up with here and put them into those plans. If we are looking at eliminating mother-to-child transmission, yet the majority of the mothers who are living with HIV do not know their HIV status, will not just get there. So almost all countries that have a high burden of HIV have national strategic plans. And in this conference, we have our leaders. They should be able to mobilize and coordinate and get those innovations into our plans.
But let me follow up on that, because you're talking about going back and making plans and doing things that sound to me like they're going to take a long time. And yet, if we're talking about the end of AIDS, whether it's 12 or 26, but if we're talking about focusing on immediate action, what are you going to do beyond talking to people about making more plans?
That's right. We can do things quickly in an emergency mode, but my take is that will take us some far, not necessarily very far, until we institutionalize these issues and we make them part of the national roadmaps, and everybody buys into that and becomes a blueprint such that things are done in a consistent manner, not one CBO here putting mothers on treatment, single dose nevirapine, another one is doing something else. That becomes chaos. At some point, we need to get organized, and we need the leadership to facilitate this process.
Debbie Briggs, do you have a comment on that? Because I'm just wondering, you know, in Africa, everybody talks about the talk shop and how everybody gets together and they have great intentions and they talk about it. We want to know what you do about it beyond more planning. Everybody seems to know what to do, but yet when you talk about it, everybody wants to come up with a new plan. How do you just get action on the ground now?
Well, I think the reason that we have the UN AIDS report that we have today that shows the plummeting incidence in the majority of countries is really the dedication of the people on the ground, who, when there wasn't a clear plan, knew what to do and did it and made sure it happened. And I think we have to really applaud those individuals. There are many countries that were very resource poor in human capacity. But I've been to those hospitals, I've seen the sisters, I've seen the matrons working long hours to ensure that all of their population that's in that clinic is reached that day, even if it takes them till 7:30 or 8. So I think the action is happening because we're seeing amazing results. So I think maybe there are some that are working still on plans, and certainly there is important to stay current and modify the plans, but people have worked, and people have worked very aggressively.
Okay, let me throw out something that I just read the other day, Zimbabwe, and I was very surprised to hear the Secretary of State compliment Zimbabwe for something, because Zimbabwe has been on such a bad case list for so long with so many countries. But Zimbabwe had a very successful AIDS program. But I've recently read that they are very worried about being able to maintain that success because they don't have the resources. And everybody here says it's got to be, it's not a matter of resources, but the Zimbabweans who've been very successful are saying it's a matter of resources, that there's a limit to how much more time they're going to be able to maintain the success that they've achieved if they don't get resources from the international community. Dr. Fauci, can you talk about that a minute?
About resources for the international community.
Yeah, because, I mean, you know, even when you've had success, as Zimbabwe has had and several other countries, they say they are now at the brink.
Right.
If they don't get more funding, and yet PEPFAR and the Global Fund are reducing their funds. Am I living in a dream world to think that resources are not a problem or an issue?
No, you're not. You're making a very good point, but there are several ways when you have limited resources to address the problem. One of the things that has been actually a success with regard to PEPFAR and the Global Fund is to have the countries that are the host countries start to take a serious look at assuming some country ownership of their problem. So we've really got to get away from the paradigm of donor-recipient and more partners that can then transition into countries that can actually take ownership of their problem. That's one of the ways. In fact, there are some really good examples in Southern Africa of countries who are now shifting away from dependency on PEPFAR or the Global Fund and are doing it themselves. Countries like Rwanda and South Africa and other countries are doing it. Botswana are doing it more and more. So I'm not at all even slightly suggesting that resources are not important, but when you have flat resources, I don't know if Eric Gooseby has yet made that point, because we've been on a lot of different panels together, but the point he makes, for example, is efficiencies. Efficiencies really count. There are things that we were doing for 5 times the cost of what we were doing years ago that right now we're doing for 1/5 of the cost. So the idea about here we are, and if we don't have more resources, we have to figure out ways to do that. And that isn't just kicking the can down the road, because there are good examples of countries who've actually done that.
Right. Mike, you had a quick intervention,
really,
and then
not
Helen,
an,
and
just
then
a
we
real
go
quick
to the
comment.
next question.
Real quick, many of us contributed to the journal Health Affairs this month. Health Affairs had a series of articles, and 3 of those were macroeconomic articles. They argued that countries where treatment was made available had rising economic benefits and rising GDP because the workers are healthy and not missing work, and businesses are doing better. That money can be reinvested. And so there's an economic benefit that could be reinvested. And these are economists writing these articles, and I thought they were really intriguing.
Right, thank you. Helen, briefly?
I think, although we were told we couldn't talk about resources, the reality is that many people in this room know that with the withdrawal of things like PEPFAR, the downscaling in the Global Fund, that services are stopping. Particularly NGO and community services are being cut. So we need to be realistic. If we're talking about moving towards ending the AIDS epidemic, we can't do it at the same time as cutting resources, notwithstanding all of the efficiencies. The second thing is that we need to then be creative. Certainly, I do think that the global world needs to be very mindful of the poorest countries and to really take care of the poorest countries while really encouraging low and middle income. So we need to have gradients. And the third thing is we need to be creative about the sorts of Robin Hood taxes that we can start to raise for global health generally, because this is HIV, but there are many demands, and we're going to have to find alternative sources of funding.
Thank you. Yes.
Hi, Owen Ryan from amfAR. So Secretary Clinton in November, when she committed to the AIDS-free generation, focused on 3 interventions: medical male circumcision, PMTCT, and treatment. Today she added a 4th around focusing on key populations. I'm wondering your opinion on whether, is that the next step? Are those the 4 things we need to invest in immediately and start to push to scale? And on the other side of that, what are the things we need to stop doing then? What are the things that we no longer need to invest in?
Who'd like to take a crack at that?
Well, I think immediately after her speech, Ambassador Gooseby tasked all of us to come up with a comprehensive and, towards pediatric elimination. So there's a PMTCT strategy that's extraordinarily strong. There's a strategy for male circumcision that we're held accountable for month after month, reporting on the numbers. And the same way with the treatment numbers, not to minimize the counseling and testing that has to occur to be the umbrella around all of those activities. As well as the focus, we know that as the epidemic becomes more and more contained in the heterosexual drivers, that there will be key populations that are particularly difficult to reach. We talked a little bit about stigma. Some of these populations highly stigmatized, particularly in sub-Saharan Africa, and I think that sentence was really calling out the need for attention to all populations as we move forward.
And that brings up a point I wanted to raise also about, we hear that one of the fastest, if not the fastest growing population of HIV infected people are women. And we keep hearing that male circumcision is solving the problem for men. Are there any specific things happening with regard to the stanching this flow, this rapid increase in infections among young women and girls?
Well, NIH is investing quite a bit in new, important scientific elements specifically directed to preventing infection in women, but I think we also have to remember that WHO and UNAIDS and certainly Ambassador Gooseby have really rallied around the call of making sure that treatment's available to all women, ensuring that B+ for all women at all times becomes available. Many countries, I think it's now up to 13 countries, have really moved to that initiative. That is huge. That's huge, because if a woman has the ability to go on therapy, there's not the question of breastfeeding transmission, there's not the question of getting to the clinic late for the next pregnancy, and there's the importance of the mother and being available to raise the children and bring in the fathers and their significant others for treatment and testing. So we know that women can provide a significant health leadership role.
Briefly, Helen Reese.
I think that we also need to really critically look at how we have failed women, because we've had technologies that should have helped women that we just haven't rolled out. We've had the female condom, it's gone nowhere because there hasn't been political support for it, although that hopefully will change. And in addition, we know that gender-based violence is a massive problem, and we've talked about it endlessly at conferences, but we failed to do anything about it. So I do think that we have actually neglected women, and that we need to be very brave and put packages together now for young women particularly that are very specifically targeted them and really thinking out of the box in a way we haven't done before.
Just be patient, because I'd like to get Mike's quick comment on this.
Oh, I just think, I agree with Helen completely. I think that we haven't been very bold, and that there are all kinds of research proposals that are very specific, that focus on Helen and her group really published landmark work that demonstrated that young women acquire HIV at an incredible rate from 16, 17 to 24. And it is possible to prevent those infections, and one really needs to be courageous, do things that we haven't done before, and bridge these women to a slightly older age where they'll probably have very different behaviors. And I think that's one of the highest priorities of at least the funding I'm involved with, which Tony's responsible for. So.
Thank you. Yes, you've been very patient.
Hi, my name is Tasha Zamborski. I'm an undergraduate at Davidson College. I am curious about the fact that when a vaccine is made, how is implementation and distribution going to elongate the kind of goal to ending AIDS?
Dr. Fauci?
Well, the way we handle vaccines now, that when you test a vaccine in a particular country, you really won't be allowed to test it unless you have a plan beforehand for the distribution of that product if it's successful in the country. That's a little bit different from years ago where vaccines were tested and then not necessarily benefit the people at whom they were tested. So it's sort of an ethical understanding now that if we test a vaccine in South Africa or in Asia, we being the Western world, with Western companies and Western funds, that you have a moral obligation to make sure there is a plan in place before you start, that the people within whose country you test it have access to that at a reasonable price.
Thank you. Yes, Jesus. Sorry.
Yes. My name is Sister Barbara Staley, and I work in rural Swaziland in an HIV/AIDS organization. under the topic here, getting real about getting an end to the end of AIDS, the question I have is, I stand in awe at what has happened medically, scientifically, but it's very strongly a medical model of services. What we encounter continuously, I have an organization that has almost zero default, almost 100% adherence, et cetera, but in the end, the real problem ends up in understanding the social sciences of people. So are we thinking about engaging social scientists in getting strategies to further implement and be more efficacious in the implementation of the scientific knowledge that's available? And when we talk about ending AIDS, are we also talking about and thinking about and giving our intellectual capital towards ending the impact of AIDS, which is the orphan children that will cause a sociological problem far longer than people who live with a chronic illness?
Thank you. Who'd like to try that one? Okay, Millie.
Thank you so much. That's a very interesting issue. Sometimes when we are in these scientific meetings, we often forget that science does not work in isolation. As we have seen, even if there are drugs, ARVs, if people are not supported by a social mechanism, they will not be able to take that medicine. So the role of behavioral sciences is very, very crucial in facilitating this process of beginning to get to the end of the epidemic. Issues of encouraging people to get tested. The doctors sitting in the clinics will not be able to do this. Somebody else has to do the mobilization. So we need to be galvanizing the partnerships of the different players, acknowledging the different comparative advantages each party has as far as getting us to the end of the epidemic.
Is that happening in Kenya?
Yes, it has started to happen. I think when we talk about combination prevention, we give room to the science, all science, including social sciences. And when we talk about stigma, we are talking about mobilizing communities, educating communities, which is part of combination prevention. It is not just the clinical and biomedical. And I agree that we have room for social and cultural scientists to help us in this fight.
Thank you. Yes, please.
Thank you very much. My name is Bisi Alimi. I'm from the UK and a member of AVAC PX Royal from Europe. Now, my question is, we've been having this conversation, and the new language we're using at this conference, that's something I've fallen in love with, is a prevention toolbox. Can I ask all the panelists, if you are to put anything in your treatment toolbox to end AIDS, what will it be?
Maybe we won't have an answer for everybody, from everybody, but let's start with you. Nelson.
Probably I'm just going to repeat what I have said, that we are talking about taming the virus, which I believe I carry in my body. And if I can tell you, if without any accident, I'm going to live for the next 40 years. If in the next 40 years, I don't want to give this HIV to some other person, the only thing I need is treatment. So give me the ART that improves the quality of my life, it stops with me.
Helen,
if you do that to other populations, it will do the same.
Helen, what would you put in the toolbox?
I'd start with an enabling legal and human rights environment. Then I would build on with interventions, starting with counseling and testing linked to treatment as prevention. Prevention of mother-to-child transmission, medical male circumcision, treatment of STIs, and...
Your toolbox is expanding.
I thought I was allowed to put everything in. You want me just one or two things? But I think the point being that, and then key populations, but I think the point being that unless we have an enabling legal and policy environment and a human rights environment, those biomedical interventions are not going to reach the people they need to reach and have the impact they should have.
Chris, you wanted to say?
Well, I just wanted to ask, actually I'd like to ask each of the panelists a question, which is, if you look forward to the next year, 18 months, and you could have one thing happen, a decision made by a major donor, governments in a region do a particular thing, an investment made, a change made in the way systems work, what's the one thing you want to see happen to accelerate the goal of an AIDS-free generation in the next 12 to 18 months?
Let's just get the panelists who wants to answer that, because if we do everyone, we'll be here all night. And then we can get some more questions from the audience, because I've got some people in the back. So who most would like to answer that? Debbie?
I'll just be very concrete. I'd like to have viral load in resource-limited settings.
Sorry, I can't hear you.
I'd like to have viral load available to all patients in resource-limited settings so that we would know adherence and staying on therapy.
Mike?
I'd like to see the 350 goal met across, stop talking about the treatment mortgage, stop talking about, the resources, and get everyone, before they fall below 350, to be treated, because I think the incidence would fall dramatically if we did exactly what PEPFAR is recommending.
Okay, I'm going to have to get to some of these other people, so if you don't mind not having everybody answer. Yes?
What about back mics? You've not used the back mics at all. Is there some stigma back there?
I'm sorry, I can't see you. Why don't you come back to the microphone and we'll entertain your questions with great apology.
Thank you.
No stigma.
I hope not, but I certainly feel like there is. My question is to any of the panelists, what about the efforts on the grassroots level or the ground roots level, whichever way you want to call it, about utilizing individuals in the community that are willing to be engaged and be part of the solution?
Well, you're in the back of the room, so maybe you didn't hear, but there's been a lot of talk about that up to this point.
No talk, no action.
Sorry, Millie addressed that. Does anyone want to add to it? Because I think...
Can you repeat the question for me, please?
He wants to know about grassroots involvement, and I think you've talked a lot about that, and so has Deborah. I'm really sorry, sir, but maybe the acoustics in the back of the room aren't great. Yes?
Thank you so much for raising that and reminding us.
I thought you had answered that question. Did you not answer that question before?
Yes, I did talk to that, but just to re-emphasize the role of communities in facilitating processes of getting people who need services to the services. As we said, nobody can work in isolation. The grassroots communities, the old women in Africa, the young people have a very critical role that needs to be recognized.
Thank you. Yes.
Hello, thank you all for being here. My name is Mariel Ryland, and I'm an undergrad at Seattle Pacific University. And my question is, with global cuts to funding, as we've all been talking about, there is obviously a need for specifically sustainable funds from especially developing countries, like Dr. Artwoma said. And so my question is for the panel, how can we turn the proven macroeconomic benefits that you were talking about earlier from countries with consistent treatment, how can we turn those economic benefits back into the proven treatment programs? Or turn them back into, like, as in just going back into the funding so that we don't have to rely as much on global funding?
I think, first of all, I'm not an economist nor a macroeconomist, just a simple scientist type.
Good.
but I think that the economists say, well, first we heard this morning about what someone called a Robin Hood tax. That is, that some of the wealthier countries contribute. Second, I think that you have to make transparent the benefits. And most of us realize that there was nothing but coffin makers down the road from the airport to the city in many of the places we've worked. They're all gone. They're now chair makers. So the benefits are visualized of treatment, well visualized. So I think those governments need to recognize as they take ownership that the improved economies in some sections of the economies, that they need to be reinvested, in modestly reinvested in improved infrastructure for healthcare and the life-saving ART that we've heard so much about.
When we talked earlier about having a greater overall degree of coordination, I'm just wondering, is there any organization that takes these specific episodes of progress or incidences of progress and shares them with, say, a Uganda, which might have a problem in some area that maybe South Africa has resolved, or Kenya has resolved the problem that maybe Nigeria hasn't. When we talk about coordination, is there any, or you also talked about efficiency, and when we talk about the lack of resources and the fact that local communities and local governments and even national governments are going to have to take more of the responsibility in these areas, are there ways, is there some organization or structure that can share with all of these some of the more successful things or things that they are, you know, having problems with, particularly efficiencies regarding finances?
As far as the global response to HIV is concerned, to the best of my knowledge, the UN AIDS has got that mandate. But as we recall, the UN AIDS is a consortium of different UN agencies. And each of these agencies, again, bring the best of their talent on the table. There is the World Health Organization, which deals with medical issues. There is the UNFPA, which deals with issues of prevention. There is the UN Women, which deals with issues of gender and women. There is the organization, you know.
So if there are questions that smaller countries have about efficiencies and economics and so forth, there's somewhere they can go.
Yes.
Thank you. Yes?
Dr. Paul Bellman from New York.
Can you come a little closer to the mic?
Dr. Paul Bellman from New York. It seems that the treatment as prevention paradigm really is a potential cornerstone for achieving our shared goals as a process. And so my question for Dr. Cohn and any other panel member is, are we taking and can we take the initiative here and really roll this out in a way that does reach the vulnerable communities in which we are seeing an unfortunate maintenance or lack of diminishment of the new infection rate? Are we doing enough? Are we considering the psychosocial elements enough?
I think in the United States, Tony talked, I think this morning quite elegantly, about really heroic efforts to deal with this in urban areas in the United States in kind of a feasibility setting. And Dr. Alsada was here earlier. I think that's the roots of the beginning of this. It's not complacent. It's a heroic effort in urban areas to identify people who are infected and offer them treatment, link them to care, and end what we call the cascade now. So I think those efforts are going to be redoubled. I'm quite sure. I mean, 10 different people. Tony, you might want to talk about it.
Yeah, it's really a great question. And when we embraced the concept of treatment as prevention, being right here in Washington, D.C., we partnered with the Department of Health and GW and asked the question, this is really a great idea, but in a city of a prevalence that at the time was about 3.2%, mostly an African American community, rather than just saying that the results from 052 were so startling, why don't you just do it? We started to ask some fundamental questions of, can this really be implemented? Can you actually access people who generally are mistrustful of the medical community, people who are disenfranchised, and people who have phenomenal stigma among particularly men who have sex men in the African American community? So we started a program that was done between South Bronx and Washington, D.C., in which we just came in saying we need to learn how to do this. How do you penetrate? How do you convince people to be tested? Will they be tested? If tested, will they come back for their results? If they do, will they then get linked to care? If they're linked to care, will they then take treatment? And if they would then take treatment, will they stay on treatment? These are the entire cascade that if you don't follow that right to the end point of bringing your viral load to below detectable level, the entire process is as weak as the weakest link. So that's what we mean by we say we're dealing with a really complicated issue. So that's absolutely a great question.
Thank you. Anyone else have a comment on that?
Well, I think from the developing country perspective, I think it's been a little bit different. I mean, I think what's just been described is really admirable, but in a sense we haven't had the opportunity to be so nuanced. So, but I think what's been very effective in our settings have been a major mobilization around testing, to say get out there and get tested. We didn't do such a good job of linking those people who were tested into care, but nonetheless, I mean, we went to 15 million people being tested in a 15-month period from a portion of that in South Africa. And that was the thing that really started us to get people who are not accessing treatment into treatment.
Thank you. Way back in the back, I don't want to get accused again of stigmatizing the back of the room. Sir?
Thank you. Ron Hattis from Beyond AIDS. And I wanted to ask if Dr. Fauci and others thought that it is possible to eradicate a disease, a communicable disease, or even to drive incidence and prevalence down steadily without giving more emphasis than we have traditionally given in the case of HIV/AIDS to control at the source being the infected patient. When we don't have a great record at CDC or anywhere, or WHO or anywhere else in eradicating communicable diseases, but for example, with smallpox, it got to the point of trying to track down every single person who was infected and to take the preventive measures around that case to isolation and quarantine we don't use for HIV, and we don't have a vaccine, but that's what they used. We would use treatment as prevention. We would use testing of contact partner services. But traditionally with HIV, we've looked at whole communities and done education, condom, things like that. But now is it time to base the prevention at the source, control of disease at the source, for which treatment as prevention is a perfect example.
Okay, thank you. Can we get a comment from you, Dr. Fauci, on that?
Yeah, what he's referring to is contact tracing, which has always been a real issue with regard to issues of stigma, et cetera. And you're right, you can make a good argument of why we have HIV/AIDS exceptionalism where you don't do that. It's a little bit different with smallpox because of the homogeneity of the vulnerability and the susceptibility and the risk. And I think this is a real difficult problem, that in a perfect world you could do that, but when people wind up getting discriminated against, lose their homes, lose their insurance and things like that, to do the kinds of contact tracing in a perfect world would be the way to go. But it just hasn't happened that way, and I can't say that it's going to change. The closest we can get to that is by being very aggressive in the seeking out, testing, and identifying and getting people to share. That's kind of the poor man's version of a strict contact tracing.
Thank you. Over here.
Hello, my name is Grace, and I'm a public health student at GW, actually. And I have a question for some of the U.S. public health leaders. And I was,
Speak up.
Sorry. So before you guys were mentioning that we do have plenty of plans and resources and guidelines in place. And I was just wondering if someone could comment on efforts to communicate those plans and hold providers accountable to those plans. And specifically, I'm thinking of the 2006 revised recommendations for testing in healthcare settings. And I'm coming from a place where I live in DC, and I have adult friends who have gone for STD testing and who had to actively ask for HIV tests. I've also working on a pediatric screening program, and I'm encountering healthcare workers who don't know how to approach their patients. They don't know how to discuss HIV. And just if you could talk about, we have plans, they're great, but how do you communicate those plans? How do you advocate for them? How do you get them to act on them?
That's a great question, and I'll be really brief. I do think that we've not done a great job in medical education in helping people to understand how to do this kind of work. And it seems pretty clear to me that this isn't quite the work of the treatment providers for HIV-infected people. You're asking a different question. You're asking about emergency rooms and clinics with family docs and urgent care centers. And I believe and each state is a little bit different. But the Affordable Care Act and most of the forward-thinking healthcare in this country has all kinds of metrics, and we're really held to those metrics. So, for example, you have to manage certain diseases in a particular way or you don't get paid. I believe that that's not bad, in my opinion, and that some of those metrics will certainly include HIV testing, sexual history and such. And Chris and Mitchell may know even more about this, about the Affordable Care Act, and some of the metrics that are tied to it. Ryan White, of course, has a huge, when we manage an HIV-infected person in the United States, we commit ourselves to the Ryan White metrics if we're Ryan White supported, and they're very accurate.
But are those metrics communicated to healthcare providers who are having problems offering testing and conducting testing?
Absolutely. Those metrics that are used in the HIV clinics that are supported by Ryan White,
right.
Everything's communicated. Now,
right. I'm not talking about Whitman Walker. I'm talking about...
You're asking about a broader scenario,
yes.
And I think that scenario will evolve in the Affordable Care Act. And maybe Chris and Mitch would. No comment from you?
I just think in the interest of time, if we wanted to take these last two and wrap up.
Okay. Maybe you can follow up after. Thank you. Yes.
Hi, I'm Ari Halper-Stromberg. I'm a student from New York. My question is, how does the NIH and other funding agencies assess preclinical data when deciding to launch a new clinical trial, especially for new therapeutic interventions where the current ART therapy is so well established and it can be so unpredictable what will happen to patients if you take them off of that? And how does this compare for HIV to other diseases where there might be more options to manage patients with other therapies?
Debbie or Dr. Fauci?
I'm sorry, you're saying how do we evaluate going from preclinical data to a clinical trial? Like, you've got to give me an example because there's a lot of preclinical data. In what? Therapeutics, vaccines, prevention?
Yeah, specifically for therapeutics, what's the criteria for assessing something and comparing it head-to-head with ART, which is so well established? And if you're going to design a clinical trial, you have to compare someone by possibly refusing them ART therapy, an option of a new therapeutic intervention when ART is so well established.
Yeah, in other words, something that isn't an antiretroviral but is somehow going to be therapeutic.
Yes, yeah, what would be the bar of preclinical data?
I'm sorry, but you're giving a hypothetical, and we take things on a case-by-case basis. If it isn't an antiviral, what is it?
Potentially an antibody, gene therapy.
Sure, okay, so that's good. Now, so you're saying suppose somebody has an antibody for HIV that's a monoclonal antibody that you want to put the gene into a vector and give it to people to be pumping out, okay? You'd have to have very, very solid preclinical data. And then if you did a trial, you'd have to do first a safety trial, and then you'd have to do a trial that compared standard therapy, which is failing, with standard therapy plus this particular. And I could tell you the chances of that getting into a trial is that I doubt, unless it's really, really hot in preclinical, that I don't think you'd get a company sponsor to do that. So I think the chances of it happening would be really small.
Thank you. We are about to wind down our session here, and I'd just like to ask everybody the last two people who have questions, let's remember, and then I do want to go quickly with the panel on our major theme, which is getting real about ending AIDS. So I want our panel to begin thinking about 3 sentences they can give me at the end of these last 2 questions, how we can get real, something that this audience can take away with them back to their communities. So I've given you fair warning here. So let's have, and let's try to stay on the point. Yes, ma'am.
Hi, thank you. I'm Emily Bass from AVAC. Debbie, we know there are large sums of money in what's known as the PEPFAR pipeline in some of the countries that we're talking about, including Uganda and Kenya. And while there's been progress, there has also been a challenge in getting the country operating plans, which dictate what countries are doing, to sync up with the amazing direction that the leaders of the U.S. are giving. Can you give us some sense of what advocates should be looking for as metrics of progress for PEPFAR specifically? And Nelson, I know you're very actively engaged in trying to release the PEPFAR pipeline in Kenya for treatment. What are you going to be looking for in the next year?
I'm glad you mentioned that. We're taking the pipelines very seriously. I know Ambassador Gooseby is, because money that is sitting at a partner level that's not being spent is a problem for all of us right now when we have all of these needs on the table. And so that's being taken very seriously, and we've been given clear direction not to fund partners that have a substantial pipeline, and to make sure that that money is available, because what we didn't talk about, we have momentum in so many countries, but we have other countries that need momentum, that where we know coverage is under 20%, and there's many issues. It's not always just a funding issue, but it's a focus issue. So I think Ambassador Gooseby, I think, is doing two things. One, looking very closely at pipeline to ensure that no new dollars are committed if there's already dollars pre-existing, and then ensuring those new dollars are invested in the most proactive and impactful way. And that will be addressing other countries with huge needs that really need to move forward in a rapid basis.
Nelson?
I think for us it was a very good first step that we even got to know that PEPFAR had money meant for Kenyan, but it was in the pipeline stuck somewhere. This was, I think, a top secret, but we got to know it, and we engaged both the Kenyan government and the US, the PEPFAR team, and what we need and what we have leveraged from them is that there's a commitment, this money is coming to Kenya. And if it is coming to Kenya, for us, it is for treatment. And we are going to follow in the next 3, 6 to 1 year, so 12 months, to make sure that this money is put to accelerate, expand the number of people who need treatment, including facing off stavudine, modernizing our treatment, and making sure that mother-to-child transmission program is expanded.
Thank you. Last question. Yes, sir.
It's not a question. It's Bob Chen, CDC. I have a suggestion for Chris in terms of response to this question. So in general, in public health, we don't move from a theoretical possibility of disease control, eradication, to the end point. We need to actually have a proof of concept in a certain geographical area. So for polio eradication, smallpox, etc., we start off with a country or a continent, etc. And so it seems to me that a key first point is to define a geographical space, be it a country or a city or whatever, that in which we have shown that it is possible to get to whatever tipping point that we want. And so perhaps, Chris, you would want to have an award, just as we have an award for the first space, whatever. We offer an award to first jurisdiction that gets to the end point that would more or less show the proof of concept is possible to get to where we want to get to.
Thank you. If I could now begin to wrap this panel up, and ask each of you, because I've given you 30 seconds or more to think about it, we would like the remaining people in this audience to be able to write down one thing that they can take back that will help make real this gradual move toward the end of AIDS, however long it takes. So, speaking from your own perspective as an activist, as a researcher, as what all of you are in your individual capacities, give us one thing specific that they can take home with them. Starting with you, Nelson.
Thank you very much. Allow me to address the different topic of resources in the respect of science. And we are saying that in our countries where this science should work most, resources are coming also from external resources. Yes, in Kenya, Uganda, and African countries, we still need PEPFAR, we still need Global Fund. However, we are asking PEPFAR, Global Fund, and all these bilateral partners to fund our countries in a manner that leverage our national resources. So they need to join activists in our countries to help us leverage domestic funding for treatment, if it is treatment that we are talking about. PEPFAR already is doing this in Kenya, and the first money that was put on ART was put because PEPFAR put a condition to say, we will give you this if 10% annual increment is put down. Global Fund should follow the same so that we sustain the science that we are talking about.
Thank you.
I'm going to stay with 3 sentences, which was for your exact command. You know, it seems to me that we spent 30 years of hard work and a huge amount of money to develop tools we put in a toolbox that have all been laid out over and over and over again. Among those tools, to me, the sharpest and most critical tool is antiretroviral therapy, which clearly allows people to survive and have normal lives and serves as prevention. Use it.
I guess I look at this very personally. I think each of us here needs to go back and ask ourselves every day, are we doing everything we could possibly do that day to further the end of the epidemic? And to each of us going back to every country, ask that in your country. Is your country doing everything it can to end AIDS? And I think together, that is extraordinarily powerful, but some of us don't hold ourselves accountable enough to the really important goal of ending this.
The one critical thing I think we need to be doing at this point in time in the age of the AIDS epidemic is delivering clear messages so that the communities do not get confused about what we are talking about. If we are talking about getting to the end, people should not think the epidemic is over and lose our guard.
Thank you.
If we really believe at this point that this toolbox has got sufficiently sharp tools, and I differ from Mike in that I think that there are all the tools, PMT-CT being one of them, you might say that's ARV, but I think we need to look at that, medical male circumcision, condoms. I think we need to take all those tools in the toolbox. If we believe that that is now sufficient for this tipping point to begin, then what I would want us to do is to seriously look at scaling up with targets at a national level with sustainable funding to maintain what we're trying to do.
A little bit similar to what Agnes just said. I think people walking out of this meeting, if they think because we've had a real enthusiastic meeting in Washington that the pandemic is going to end, they're making a major mistake, which is self-destructive. I think, as I mentioned in my lecture this morning, we can do this, but this is going to take a very long time. That's going to require a completely sustained commitment. If you stop, slow down, get distracted, do something else, we will lose this.
I have one thing, and that is to thank this incredible panel and to thank Charlene. And I'm going to take the opportunity to answer Charlene's question as well. For me, it's reminding ourselves, there was a moment a number of years ago where the 3x5 initiative, we didn't need it, but we have 8x12 because we had 3x5. And I would argue we need a new measurement metric, not for ending the epidemic, but for the next 24 months. How many people on treatment, how many circumcisions, how many things do we need to do, and monitor it month by month. And when we're not meeting our target, we need to course correct. And I don't think we're doing that yet. So I would really love to see that 3x5, and I'd love to see us be able to come back to that and really monitor it in real time.
Well, I also want to thank this amazing panel. Thank you so much for coming tonight and sharing your ideas, and to everybody who came tonight for your questions and for being here. Our two organizations are committed to following up on these ideas, as Mitchell said, to tracking progress against the ideas that were raised here tonight and also in our report. We'd love to hear reactions to this report. Where did we get it right? Where did we get it wrong? We're interested in building some kind of an accountability mechanism that can raise issues about what the tough choices are ahead and see how we do on them. There's a website, endingaids.org, where now you can see this report, but there will be more accountability related pieces there in the future, and we'll let you know about them. So again, thank you so much to the panel and to everybody who came tonight. Good night.
Few could have imagined that we'd be talking about the real possibility of an AIDS-free generation. But that's what we're talking about. That's why we're here. And we arrived here because of all of you and your unwavering belief that we can and we will beat this disease. And this is a global fight, and it's one that America must continue to lead.